Thank you, Chairperson. I like to thank Vijayakumar sir for the wonderful opportunity given to me. And this talk is, I have a disclosure too for this talk. This talk I have signed agreement with Astra for this talk. So we know that type 2 diabetes management is has to be individualized, as with our Dr. Ranjit also told about it. It's very difficult to manage type 2 diabetes to the recommended guidelines to have achieve a cardiorenal composite endpoints. We treat diabetes to have reduce the cardiovascular morbidity and mortality. Always, type 2 diabetes come with the risk factors or associated comorbid conditions. We not always type 2 diabetes comes alone. Always it comes as a package with hypertension, obesity, dyslipidemia, microalbuminuria. So how to take care of these type 2 diabetes patients? And is there any difference in managing these group of patients? If we all know that UKPDS told us that bringing down the sugar by less than 7, we can able to avoid complications. How early do we need to bring down? Whether at the time of onset, are we delaying in HbA1c control? Are we delaying the complications rates? And how about managing type 2 diabetes with CKD and heart failure associated disease? This is data from each decade. The diabetes onset will delay the life expectancy by 3 to 4 years. If a patient has been diagnosed type 2 diabetes almost at the age of 30 years, the life expectancy last will be almost 14 years. For the age of 40 years, he lost life expectancy almost 10 years, 50 years, 6 years of life expectancy. Almost every decade, the life expectancy delays by 3 to 4 years, irrespective of male or female. So the point we need to mention here is, so we need to prevent diabetes. If at all we can able to pick them very early, metabolic syndrome itself, or if they have a pre-diabetes, we have to pick them early. We have to educate them about lifestyle modification. If at all, if they develop diabetes, we need to treat them early and aggressively to prevent complications in their future part of life. This is also interesting data from UKPDS retrospective analysis. This is about almost 1 lakh patients has been studied here. What they have assessed here, if there is any delay in treatment of hyperglycemia, what will happen in the management? This data suggests that even 6 months delay in HbA1c control, intensive glycemic control, significantly increases a myocardial risk, particularly myocardial infarction has been increased. It also increases cardiovascular event. So we need to be very aggressive, not only aggressive after 5 years of life or for 10 years of life, at the time of diagnosis also we need to be aggressive. We also discussed that type 2 diabetes comes as a package. Any cardiovascular disease patient, if you take up, the patients will have diabetes, almost 1/3 of patients will have diabetes, and 1/3 of type 2 diabetic patients will have microalbuminuria to macroalbuminuria. So we say that type 2 diabetes has to be looked in a comprehensive way, like hypertension, dyslipidemia. Now this thing has been changed. We have to take care of type 2 diabetic as whether the patient have microalbuminuria or macroalbuminuria. We need to take care. Is the patient having, is there any cardiovascular risk is underneath behind that? So our management totally differs between the patients, individualized patients. If you go with type 2 diabetes with one single risk factors, particularly dyslipidemia or type 2 diabetic with elderly population, dyslipidemia, hypertension, with or without albuminuria, totally the scenario changes. Why this scenario changes? This is from KDIGO guidelines data. This type 2 diabetic with low risk, type 2 diabetic with moderate risk, type 2 diabetic with high risk and very high risk, particularly the cardiorenal composite outcome will be very worse for the high risk and very high risk population. This is almost 50% of these population will end up in cardiorenal composite outcome, bad outcomes. So we need to be very aggressive to prevent this progression of moderate to high risk or high risk to very severe high risk, we need to be very aggressive early management. Also, we need to be focused on this group of patients to avoid long-term morbidity and mortality. So, if having said that, what are the risk stratification guidelines? Is there any guidelines to go with that? And what about KDIGO suggested how to risk stratifications? There are so many risk stratification methodologies available. Clinically, we see the patient, whether the patient have obesity, hypertension, and dyslipidemia, microalbuminuria. We can able to, it is easy way, or we can able to individualize. And risk calculators also available, like UKPDS risk score, Framingham risk score, FIP4 score for MASLD, or EGFR calcification. There are so many calcifications are available, and guideline based therapies, we do have a guidelines as per the ACA, ADA, ASD. So many guidelines has been given us, and imaging technologies, particularly this contrast technologies on coronary CT angiogram and stress test, stress echo will guide us. Specific suboptimal atherosclerosis can be picked up here, and biomarkers, particularly NT-proBNP, HSCRP, troponin. All these parameters also help us to stratify the patients based upon the risk associated with them. So, this is well-known documented evidence from KDIGO. We all know that type 2 diabetes initiate the cascade of heart and kidney damage, and CKD and heart failure is the commonest complications of type 2 diabetes mellitus. Almost 40% of people with type 2 diabetes will have some form of CKD. So, even though if a patient have normoalbuminuria, if the patient have EGFR comes down, it increases the risk from mild to moderate based upon, not only based upon microalbuminuria. We always look only for protein, but we need to check microproteinuria in particularly all type 2 diabetic patients, and don't go only by serum creatinine values. Always check for EGFR, estimated glomerular filtration rate. So, the risk stratification is be done based upon the proteinuria and EGFR calculation. Even though if my proteinuria is normal, if EGFR going down, they are progressing from mild to severe high risk patients. If even though the EGFR is normal, if they have a macroproteinuria, definitely the patient have a moderate risk. So, risk stratification has to be done both the way, either both the way with micro and EGFR calculations. So, most commonly we do assess about hypertension, obesity, dyslipidemia, CKD and CVD assessment as per our clinical scenarios. If you see here, almost 2/3 of our type 2 diabetic patients aged more than 60 will have more than 3 comorbidities, more than 50, almost 1/3, 50% of people will have comorbidities. If it is less than 50 years, 1/3 of people will have comorbidities. So, whatever age you look into it, so the percentage of comorbidities increases by age. So, always we have to take care of these 3 comorbidities. Why we need to take care of these comorbidities? Because we all know that acute MI will increase type 2 diabetes plus 1 risk factors to 2 or 3 or 4. As the risk factors going high, the risk of acute MI is also going high, heart failure rate also going high. Not only heart failure, the microalbuminuria rates also going high based upon the risk factors. And all-cause mortality, CV mortality also increases based upon the risk factors. So, if you have a 3 or 4 risk factors, the chances of patients getting MI is quite high. The chance of getting a CV mortality is quite high, macroalbuminuria also quite high. Why it is important? We need to be very aggressive in this group of patients so that we can avoid complications in later part of life. So, having said that, what is the evidence? How do we need to aggressive about these patients? So, which therapy will help us to manage this group of patients in an effective way? So, with the evidences, what we do have among the drugs, oral hypoglycemic agents, I feel SGLT inhibitors will be best suited drug for this high risk type 2 diabetic patients, because this benefit will be most pronounced in those patients with highest burden of the disease. If they have this drug work with normoalbuminuria, microalbuminuria and macroalbuminuria, but the benefit is huge with macroalbuminuric patients. So, even though if the patient have one risk factor, two risk factor, three risk factors, this drug, particularly the SGLT2 inhibitors, have a huge benefit for the patients having more than 2 or 3 risk factors than with 1 or 2 risk factors. So, this group of patients has to be exposed for if increasing the risk factors with type 2 diabetes mellitus. So, we all know that the mechanism of action, we have a hemodynamic renal protection. So, it reduces intraglomerular pressure, it also reduces afterload and preload, it has a improving metabolic health, energy efficiency, it also have an anti-inflammatory action with these SGLT2 inhibitors. So, among the oral anti-hypoglycemic agents, the SGLT2 inhibitors will have a strong proven cardiovascular benefit, renal benefit, hospitalization for heart failure, albuminuria benefit and weight reduction along with without inducing hypoglycemia. So, this drug suits well for our patients with type 2 diabetes with more than 2 or 3 risk factors. So, there are so much evidences available how this SGLT2 inhibitors will be beneficial in heart failure. It is even though it is a class defining effect, this DAPA-HF trial showed that the significant reduction in hospitalization for heart failure or CV mortality has been shown with dapagliflozin. The DAPA-CKD trial also proven that renal composite outcome will be much significantly reduced with dapagliflozin across the board. This benefit has been shown even in non-diabetic populations as well. So, if this is from declared TIMI data, which is a well documented data from dapagliflozin. If you see here, the type 2 diabetic with one risk factors, the hazard ratio reduction will be 40%. Type 2 diabetic with 2 risk factors, the reduction will be 47%. If the type 2 diabetic with 3 risk factors, the benefit will be shown in more than 80% of populations. So, as the risk factor progresses, the benefit also huge. This is what we want. We want to have a more benefit for our patients with more or 2 or 3 risk factors. This data has shown that DAPA will be more beneficial for if we have a more risk factors, this drug will have more benefit than less risk factors group. And this is with hospitalization for heart failure. Hospitalization for heart failure also significantly reduced if a patient have more than 2 risk factors, the benefit will be huge compared to the patients with 1 risk factors or nil risk factors with the help of dapagliflozin. And this is with renal benefit. Those patients have low risk, moderate risk, high risk or very high risk. You can see that the graph is slowly coming to the left. Those patients have very high risk have significantly shown huge benefit compared to low risk or moderate risk. Across the board, all the group will show the benefit. The maximum benefit has been shown with maximum risk factors. So, we have to use this drug whenever we come across a patients with 2 or 3 risk factors to have maximum benefit to our type 2 diabetic patients. This is about cardiorenal endpoint comes down with a very high risk population than with mild risk or moderate risk group. So, dapagliflozin not only improves cardiorenal outcome, albuminuria protection also shown significant, as with if you see that macro to normoalbuminuria benefit will be huge compared to micro to normoalbuminuria. So, whenever the defect is high, the benefit will also be high with this group of molecule. We all know that this is a ADA guidelines, particularly when we have more than 55 years of age, more than 2 risk factors. ADA also endorses that SGLT2 inhibitors will be the undoubtedly has to be prescribed for more than 55 years with more than 2 risk factors. So, risk factors like obesity, hypertension, smoking, dyslipidemia, albuminuria, all across the board, the patient will be benefited with this molecule of SGLT2 inhibitors. Having said that, type 2 diabetic patients, we have so much molecule thanks to Indian Pharma, we have so much DAPA. Is there any difference in between generics and the original innovator? Those who used both will definitely accept me that always innovator molecule have a slightly superior over the generic in terms of efficacy and tolerance. This is the data from statin. What they have shown that compared to generic and innovator, the risk will be benefit will be shown huge with the original molecule than with the innovator, original innovator molecule than with generic molecules. This is with clopidogrel. Those patients have used original clopidogrel will have a 2.7-fold increase benefit has been shown with original clopidogrel. If you come across many cardiologists, we have seen so many prescriptions. After acute coronary syndrome, many cardiologists like to use innovator clopidogrel rather than with a generic clopidogrel. That is what the benefit has been shown. So always the original molecule have a superior edge over the generic molecules available in the market. So we need to understand about how this generic have been approved. This generic usually should have, this drug, generic drug, any drug comes to the market has to prove its bioequivalence. The variability will be less than 20% or more than 25%. If it is less than 20%, what about efficacy? We don't know. If it is more than 25%, what about safety? We also don't know about it. So the bioequivalence approval data based upon the bioequivalence of 80 to 125%. Having said that, when the third drug comes, it need not to prove the bioequivalence with the original molecule. Even the generic molecules, they need to just prove the generic bioequivalence with the generic molecule. If a third drug comes, the bioequivalence to generic molecule. If a fourth drug comes to bioequivalence to generic molecule, definitely the efficacy slows down. This is a biocreep analysis. So we need to be not only just about the bioequivalence, whether this drug has been studied with originator molecule, we need to understand that. And there is something called biopharmaceuticals classification system based upon the permeability and solubility. So if it is highly permeable and highly soluble, it comes under class 1 criteria. Highly permeable, low soluble comes under class 2, low soluble and highly permeable class 3. If it is class 3, if it is low permeability, this is what the absorption drugs happens. We need to worry about permeability. If the drug is quite permeable, it is easily absorbed. So glycoside, glimepiride comes under class 2 drugs. Rosuvastatin calcium will comes under class 2 drug. DAPA, metformin comes under class 3 drug. And Saxa comes under class 1. Linagliptin comes under class 2, Sita comes under, Vilda comes under class 3 drugs. Why this is important? In India, we approve based upon class 1 and class 3, there is no need of human studies. Just in vitro, in vitro studies are sufficient enough, but not like in US. US they need only, they approve only for class 1 drug, they approve the bioequivalence data from the in vitro studies. For class 3 drug, they need human studies, but not in India. Why it is important? Because class 3 drugs, we have seen that class 3 drugs, the permeability will be quite low. If they approve only with in vitro studies, without human studies, then what about efficacy, what about safety? So this is a major question. So because of our government policy, we approve that, but still we need to understand while using this drug in our patients. So innovator by dapagliflozin and generic dapagliflozin, even though the brand name, even though the formulation contains dapagliflozin, but definitely it has a difference in terms of significant number of patients have been studied with innovator, but the very less number of patients have been studied with the generic molecule, and the molecular weight is totally different. Here 502, and the generic DAPA will be 408. And efficacy also significant difference has been shown with innovator DAPA compared to generic DAPA. So having said that, is there still using dapagliflozin have impact on the type 2 diabetic with more than 3 risk factors? Definitely we can able to reduce hospitalization for heart failure and impact of cardiovascular renal outcome. Otherwise, we can able to delay the referral to a cardiologist almost 5 years in using dapagliflozin in high-risk type 2 diabetic patients. The same scenario happened with, in terms of renal morbidity and mortality also, we can able to delay the referral to a nephrologist by almost 7 years. The patient will stick on with you. We can able to, this is what we, as a physician, what we want to delay the further complications. If you want to delay the further complications of type 2 diabetic patients, always use judicious use of this molecule to prevent further renal and cardiovascular complications. So, we need to stratify our type 2 diabetic patients based upon the risk factors. Are we dealing with one risk factor or two or three, or we need to very aggressively treat our patients, those who have more than 2 or 3 risk factors, but always go with innovator molecule to have a maximum benefit. And those patients who have more than 3 risk factors, definitely the SGLT2 inhibitors, DAPA, have a proven safety profile. It improves not only glycemic profile, it also improves the reduces the complications in terms of cardiovascular renal outcomes. Thank you for your patient listening.